Hello friends, welcome to English Shorthand class. Ready? 1, 2, 3, start. Purnima and Ashok, 80-year-old parents of 2 and grandparents of 3, have been hunkered down in their Mumbai apartment for a year. When a COVID-19 vaccine became available in March 2021, they went to the local hospital to get their first dose of the Serum Institute of India's Covishield vaccine, the vaccine that was supposed to save the world. Seeing long lines and not wanting to risk being infected while waiting to be vaccinated, they returned home. This happened again the next day before a very helpful staff member of the World Health Organization stepped in to help, taking them to a health center early one morning and making sure they did not have to wait in a line to get vaccinated. This played out again in April 2021 for their second dose. This couple was lucky. Where the focus must be. As we look ahead to what is promised to be a transition from a lack of vaccine supply to one of greater availability, the plan must be to prioritize people like the two octogenarians in Mumbai, older adults who remain unvaccinated and very much at risk. Ensure we vaccinate them before we open vaccination to younger adults. This would prioritize people based on the risk of severe disease and need essential principles if we plan with justice in mind. Local governments and municipalities should also prioritize vaccines for the historically marginalized by focusing through the lens of equity and justice. What does it mean to focus through a lens of equity and justice? It would mean ensuring that the vaccine rollout does not result in avoidable differences in vaccine uptake and hence preventable disease and death between marginalized groups and the rest of the country. It would require prioritizing the poor, religious minorities, socially disadvantaged castes, Adivasi communities, those living in remote areas, and women. One example of an equity-focused vaccination plan came from the Chhattisgarh government. The plan prioritized ration card holders specifically because they are poor and often live in multi-generation larger households, putting them at higher risk of infection. They also often lack access to mobile phones and the internet, which are necessary to register for vaccination. Though the High Court asked that the plan be modified to provide vaccines to the general public alongside ration card holders, we would propose prioritization of the marginalized when vaccine supply is limited in order to minimize the risk of severe outcomes due to COVID-19. WHO's Strategic Advisory Group of Experts on Immunization recommend prioritizing socio-demographic groups at significantly higher risk of severe disease or death in the context of limited supply. We should ensure that we remove barriers to vaccination for the most vulnerable in India to minimize preventable disease and deaths. India depended and continues to depend on the AstraZeneca vaccine because it was stable in a refrigerator for longer periods than mRNA vaccines. Presumably, this was so that vaccines could be made available where freezers do not exist, but it also enables the vaccine to be transported in vaccine carriers and taken to the people where they are. In Indian villages, accredited social health activities and auxiliary nurse midwives have vast experience and expertise with campaign style pulse polio vaccination and newborn vaccination. Their expertise should be harnessed to take vaccines to villagers.